In Parkinson's, symptoms can shift within minutes, yet treatment remains fixed, unchanged for long stretches of time, no matter how the disease state evolves. What if AI could detect the earliest signs or the very onset of a Parkinson's symptom change and adjust therapy in that moment? I'm Chetan Reddy, a third-year medical student at the Perelman School of Medicine, and in this talk I'll show how machine learning can uncover these signals, known as biomarkers, and drive adaptive deep brain stimulation. By continuously monitoring the brain and the body and training algorithms to anticipate symptom changes, we can adjust therapy in real time, moving from static treatment to truly personalized and responsive care. So first, I'll start with a little primer on Parkinson's and its relationship with DBS. Parkinson's disease is the second most common neurodegenerative condition after Alzheimer's, carrying with it significant morbidity, mortality, and social cost. Medical therapy is used early on, most commonly Sinemet, and while it does have efficacy in reducing tremor, it tends to really only treat the symptoms of Parkinson's, not the cause, and over time its efficacy wanes significantly. Deep brain stimulation, targeting either the subthalamic nucleus or the globus pallidus interna, has become a cornerstone treatment for motor symptoms. And it's important to say that stimulation of either site does lead to a reduction in tremor, but depending on where you stimulate, you'll have a reduction of symptoms in a differential manner. So then what's the issue? Well, the problem is that DBS works best when it's finely tuned to the patient's needs. But finding that optimal stimulation parameter is a very tedious, intensive, and trial and error process on the side of the clinician. But even when these optimal parameters are found, there's two problems. One is that what's seen in the clinic may not represent the daily fluctuations of a patient's life. And moreover, the devices themselves are what's called an open loop system. What this means is that stimulation is set at a constant, so whether the symptoms at a particular time are mild, severe, or altogether absent, the stimulation is always going and constant. And even when the patient wants to change their parameters, they must go in and the neurologist or the clinician must manually adjust this. So a proposed solution to this is Adaptive DBS, which can change the stimulation intensity or signal based on real-time physiologic signs. Now, there are adaptive DBS in current use today, but they use external rigid thresholds that are not patient-specific. And here's a schematic kind of demonstrating that. So today, my focus will be on using machine learning and AI to discover brain biomarkers that could power adaptive deep brain stimulation in Parkinson's disease. If we can continuously monitor the brain and the body and teach an algorithm to recognize when symptoms are about to change, we can adjust therapy before the patient even notices. In my talk, we'll move from understanding the initial challenge, exploring candidate biomarkers, and finally go to translation in the real world for application. We should first understand what even is a biomarker and what makes a good one. So a biomarker is essentially a pattern within a physiologic signal that correlates with a state of health, in our case, a pathologic one being Parkinson's disease. A good biomarker has a number of characteristics, some of which I listed here. A high signal to noise ratio with minimal influence from external factors. We also want an acceptable sensitivity and specificity to make sure we're actually targeting Parkinson's disease and not too much else. For applicability reasons, we want to think about markers that are cost effective, relevant to the clinic, and also generalizable to the population of those with Parkinson's. Potential sources of these biomarkers include motor data, electrophysiologic activity, and even cognitive state measures such as sleep and speech. So where do we start? Well, we should begin with the most visible data in motor symptoms and see how that can predict the clinical severity of a patient's Parkinson's and how that can inform the parameters for adaptive deep brain stimulation. Motor symptoms are the most obvious and visible hallmark of Parkinson's. Traditionally, we measure them in the clinic through rating scales, but these scales tend to be relatively subjective as much as we try to build objectivity into them, and they really only reflect a brief snapshot of the entirety of the spectrum of the patient's disease. So the question is, how can we get objective data on on a patient's motor symptoms? Well, one way is through wearables such as smartwatches, rings, or even using your smartphone's motion sensors. They can continuously record tremor amplitude, bradykinesia movements, and even gait changes. The advantage is clear: a constant, objective feed of motor data. But of course, there are challenges. So not all of these wearables or devices use the same standardized measurements, and they also don't account for other non-motor biomarkers such as cognitive states or electrophysiologic data, which are obviously important for the quality of the patient's life. So here I've just included a graphic of the different types of wearables that patients can use for Parkinson's to source a multitude of movement data, such as watches, belts, rings, or even shoes and footwear. So now that we have identified motor symptoms or motor movements as a potential candidate biomarker for Parkinson's disease, how can we utilize ML and AI to essentially analyze this movement data and use it to inform the stimulation parameters for an adaptive DBS? And has this been done in the real world? Well, yes. And what we've seen is that when motor data is paired with machine learning, these algorithms can learn which movement patterns best match a patient's symptom severity. In real world studies, these models have shown strong correlations between wearable recorded features and clinician rated symptoms, which can be seen in this figure here. Essentially, what we're seeing is that the correlation on the y-axis between the true clinician rating of these different motor movements, so diadochokinesia, tapping, and rigidity, correlate very well with the ML predicted ratings of these different symptoms based on the movement data that were sourced from different wearables, all the way up to a correlation of 0.7. Moreover, this also impacted DBS settings. So the same features that the ML used, namely the movement data from the wearables, was able to also predict the optimal contact and amplitude settings for the DBS to relieve the specific patient's symptoms. So it showed that the true parameters, as we can see in this figure here, are significantly higher. The correlation of the parameters with the true correct clinician determined parameters and the ML predicted parameters are correlated much better than random parameters that were chosen. So in practice, this means the system could sense when tremor or stiffness or other symptoms are increasing and automatically switch to the setting that history shows works best for the patient, meaning no clinic visit is required. This essentially points to a therapy that immediately responds to the patient's needs. So beyond movement data, we can also listen directly to the brain. Local field potentials, or LFPs, capture the rhythmic firing patterns of neuronal populations. And specifically in PD, we would look for these LFPs or measure them in the STN or the GBI. Now, in Parkinson's, particular frequency bands of these LFPs, namely excessive beta activity, have been linked to motor symptoms. The limitation of this traditional analysis with the frequency bands is that it slices these signals into very broad frequency categories, and it tends to ignore more complex patterns. Machine learning can instead sift through this vast amount of raw signal data and deliver subtle but high-dimensional patterns that humans can't as easily detect, and provide rich information about the clinical state of the patient. And here I've just provided a figure that demonstrates how, when an LFP is recorded, it can be broken down into its component frequency band signals and measured and used for analysis. So here I hope to provide a real example to demonstrate this. When machine learning models are trained on LFP recordings from the STN specifically, and they're paired with symptom score data, they can learn to predict not only when the symptoms will improve with DBS stimulation, but also the optimal settings for that improvement. And a paper from Hirschman et al. Demonstrated that some of the models that they used and developed have achieved a near 90% accuracy in identifying the best stimulation contact, and even have been able to estimate the best therapeutic window. So with this, you could imagine a DBS system that continuously records LFPs and recognizes a shift towards a worsening pattern and adjusts stimulation before the patient may even feel physical symptoms. And here I've just provided a figure showing how Hirschman's group essentially recorded LFPs from the STN. Here's the data, here's the raw signal data of the LFPs and how they broke it down into its component frequency bands. So up to this point, I've shared important work that demonstrates how AI can accurately predict the clinical presentation and severity of a patient with both motor and electrophysiologic data, and how it's able to use this data to inform and optimize DBS stimulation parameters to provide targeted therapy. But the question is, how would this work in the real world, and how do we translate this to the clinic? Well, I think bringing this to the clinic means combining motor and brain data into a patient-specific, personalizable, and actionable biomarker. And ideally, these biomarkers that we use are causal. So what this means is that whatever we're measuring to inform the stimulation parameters of our DBS is ideally what's causing the pathology of the symptoms. So this is kind of a pitfall of using the motor symptoms as a biomarker, because motor symptoms are an external manifestation of the disease itself as opposed to causing it. Whereas a better argument could be made for the electrophysiologic data and having a mechanistic action and causing the pathology of PD. And like I said, using ML will in turn allow for the optimization of DBS stimulation parameters in a way that's personable and targeted and responsive in real time. And here I've included a figure that demonstrates the kind of evolution of DBS that I'll quickly go through. So first we have the electrophysiologic signal that's read by the DBS ideally, and then that in turn will inform stimulation. So what we have now is a constant stimulation pattern in which there is no feedback from the electrophysiologic signal to the device. So stimulation is always set at a constant rate. Next, we have binary stimulation, in which external kind of rigid thresholds are set, and whenever those thresholds are read by the device, it'll change the stimulation pattern to a preset parameter, and it'll flip between back and forth when that threshold is met or when it's not. And lastly, we have continuous stimulation, which is what an adaptive DBS should aim for, and especially what I think I'm proposing with this ML informed kind of method, in which that the electrophysiologic signal is continuously read by the machine, by the device rather, and is able to on a continuous spectrum adjust stimulation parameters to meet the needs of the patient as inferred by the signal. So one issue is, with using an ML kind of informed DBS is that it will require an initial calibration phase where the system learns the patient's unique patterns and then moves into an adaptive mode. Of course, with anything that we're translating into the clinic, there are challenges. So we would need large data sets to train these ML algorithms to be accurate and precise. We would also need more sophisticated hardware because of simply the computing power required to run these algorithms, perhaps including like another IPG or another battery may be necessary. We also need more long-term safety and efficacy data, but the potential payoff, giving patients a kind of continuous personalized therapy, makes this goal still worth pursuing. Machine learning is making personalized and responsive DBS a realistic goal. By finding biomarkers that reflect symptom changes in real time, we can build systems that adjust automatically, reduce side effects in a timely manner, and minimize manual programming, reducing the burden on both the healthcare system and the patient. The future is a fully autonomous, closed-loop system that not only treats symptoms but anticipates them, keeping patients in their optimal state. The question isn't whether this will happen, it's how quickly we can identify the biomarkers and make it a reality. Thank you for your attention. I'm deeply grateful to Dr. Brem and the Penn Neurosurgery Department for their guidance, mentorship, and the opportunity to present this exciting work. Thanks.